I'd like to introduce our next speaker, Dr. Ciarallo. Dr. Anthony Ciarallo is a Royal College certified nuclear medicine specialist. He trained at McGill University. He completed his fellowship in PET CT at Johns Hopkins University, and he holds a Master of Science degree in human genetics. He is currently the Divisional Director of Nuclear Medicine at McGill University Health Center, and he's an Assistant Professor of Radiology at McGill University. And today, Dr. Ciarallo will be presenting to us on sodium fluoride bone scintigraphy.
All right, thank you very much. I'm very happy to be with you today because it means I'm not on service. So I just want to say that that was an excellent presentation by Dr. Jen. Probably the best presentation on bone scan that I've seen. And it's a tall order to follow up after Dr. Jen. Just on an unrelated note, when you fill out the evaluations, please keep in mind that you can't compare me to other presenters during the conference. So I just wanted to say that. So today I'm presenting on bone PET, NaF bone scintigraphy. I have less time than Dr. Jen had, but I guess that works to my advantage because it only has to be half as good as his. So I'm gonna be showing some cases. I think, I mean, from what I understand, there's probably not too many people that have that much experience with PET bone scan. So I'm gonna try and give everyone a feeling of what it's like to read a PET bone scan and compare it to a MDP bone scan, and give you guys an idea of what our experience are, what our experience is at the MUHC. So I have no disclosures. So at the MUHC, we started scanning NaF in 2015. And between 2015 and 2021, we performed just over 9,000 studies, which averages out to about 1,300 a year. We routinely inject 10 millicuries per patient. We image 60 minutes post-injection. Initially, we're doing 90. And we routinely image from vertex to thighs and include legs as needed. So imaging times can vary, and that kind of depends on, I guess, how much you inject and what camera you're scanning on. We have two PET scanners. We have one that's BGO, that's older, and a newer one that's LYSO. So on the BGO, both have about 8 to 9 beds, I guess, depending on how tall the patient is. But the BGO, we scan at 2 minutes per bed. So at 9 beds, that gives about 18 minutes. And if you include legs, well, that's another 16 to 18 minutes. So you're looking at over 30 minutes for your study, which starts to get long. Which is one of the reasons why we just do to the thigh unless indicated to go lower. However, on the LYSO, we are able to scan at 1 minute per bed. So that cuts the exam time in half. And with new digital PET scanners, which is actually the one we were replacing the BGO with, we can imagine that it'll probably be even less than 9 minutes, or at least we'll be able to cut the dose. Regarding dosimetry, so according to guidelines, say 5 to 10 millicuries should be injected, no patient preparation in adults. Pediatric dose is stated. We don't do pediatric patients. And for NaF PET, you're looking at about 9 millisieverts for 10 millicuries compared to MDP, which is around 5 millisieverts for an injection of 25 millicuries. And when you do a CT scan, obviously increases the dose of the patient. So going from 9 to 12 and from 5 to 7 millisieverts. So just to, everyone knows this, but just to kind of remind everyone, the collagen matrix is mineralized with hydroxyapatite, and apatite is a naturally occurring mineral composed of calcium phosphate. When we give NaF, the fluoride ion undergoes ion exchange with a hydroxyl ion, which is the N member of the apatite group. So indications. The indications are really similar to MDP bone scan. I'm going to be focusing mainly on oncologic indications, mainly for time. So one of the nice things about NaF is that you can complete the exam a lot more quickly than with MDP. So you could start scanning after 45 minutes post-injection. And this is due to several reasons, because there's less protein binding, allowing for a more rapid extraction, faster clearance from soft tissues, rapid clearance from the plasma, and this ultimately results in high and rapid bone uptake as of 45 minutes. So just a few images. So on the left, so this is courtesy of my colleague, Dr. Eric Turcotte at the University of Sherbrooke. So at 3 minutes post-injection, he acquired this blood pool, 1 minute per bed on the left. And here you have the 45-minute delay on the right. So basically similar distribution as MDP. You see the renal system, and the rate limiting step of uptake is believed to be related to blood flow. So that's not very surprising. Normal by distribution, again, very similar to MDP. You see axial skeleton very well, more than appendicular. You can get uptake around the joints, obviously in the growth plates and kidneys and bladder, just like MDP. So one of the existential questions when doing NaF, to correct or not to correct. So obviously, you know, attenuation correction offers a few advantages. So the image on the left, you see that there's this spinal gradient based on the depth of the tissues and how much tissue related to the attenuation of the photons, where you get your C-spine maybe a little more intense and the lower spine a little less intense. Obviously more soft tissue activity when you don't correct, and you can even have artifacts around the bladder on the non-corrected image. At our center, we favor doing non-corrected, and I guess there's a few reasons for that. All our patients are oncologic patients, so they routinely have follow-up with CT. So all our CTs is readily available to us, and we can easily correlate our studies with the available CTs and PACs. It also avoids us from having to read full body CTs on all these patients that had their CTs just a few days before. So just to give you a taste of what NaF looks like on ordinary patients, if you could say that. So 55 kilogram patient injected with around 8 millicuries, imaged at 53 minutes. This is on the BGO camera, 2 minutes per bed, compared to the LYSO, similar weight, similar dose, 41 minutes. So you see that the image is a little crisper on the LYSO, and this is imaging half-time. For heavier patients, 100 kilograms, this is 2 hours post-injection on the BGO compared to LYSO, 97 kilograms, 90 minutes post-injection. So you're starting to get a little taste of what it looks like. These are all non-corrected images. So if you look at head-to-head, BGO versus LYSO, this is the same patient, obviously imaged at 2 different times. Top line is BGO, bottom line is LYSO. So we have similar image quality, but I'll just outline the fact that, again, the LYSO is half-time, and when the patient was imaged on BGO, was considerably later than the time point of imaging at LYSO. So patient has I guess either, I don't remember which came first, but either lost weight or gained weight. So some normal variants on NaF. Again, all the variants are the same as Dr. Jen described very well on his presentation. Just a few variants that I'd like to focus on for NaF. So for skull, we often get this variable skull pattern, often related to suture lines, can be related to sinus activity. There's this other finding that it took me a while to kind of figure out, and I think I figured it out actually, but I couldn't really find it in the literature aside from one article. So frontal process of the maxilla. I would see this all the time, and I didn't really know what to say with it. I always thought it was benign, but there is a paper that looked at 100 studies retrospectively of paranasal sinus CT, and they found that 5% of their population had fibrous dysplasia-like changes in this frontal process of the maxilla. So over time, you see another patient, and again, and again. These are all different patients. So I think probably corresponds to that. Bowel activity. So this is something that I guess maybe is unique to NaF that we don't really see with MDP. It's documented in the literature. The mechanism is unknown and it can be variable in appearance. So here we have same patient, image 2019, 2021. In 19, bowel activity was very, very mild, a little more prominent in 2021. Again, means nothing. There's another patient with benefit of CT for localization. So you can see very well that the bowel activity is in the small bowel. Sorry, yeah, activities in the small bowel. But you have to keep in mind that it may not always be bowel activity. In this case, patient has a ectopic kidney. So obviously, all the possibilities of extraosseous activity that we know on MDP definitely apply on NaF. Just a little bonus, this isn't really a normal variant, but it's something I see fairly often. T-spine facets, the residents tend to get caught up on this, especially the ones who are reading NaF for the first time, not really know what to make of it. So I guess because the increased contrast resolution of NaF compared to MDP makes it that we see this activity more often, or at least it's more obvious to us. So that's okay. You shouldn't react too much to that. However, keeping in mind that you may have a metastasis in this region. So this patient, the activity isn't quite in the facet, and it extends over the lamina and corresponds to a lesion on CT. So ultimately, the question, should I start doing NaF and switch from MDP? Well, we could take a closer look, and I'm going to try and answer that. Well, I'm going to try and answer that question for you, or help you at least decide whether or not it may be worthwhile. So it's a series of patients, the next 2-3 slides, kind of a head-to-head comparison. This is the same patient performed 1 week apart in 2 different centers. So the one on the left is a MDP SPECT, non-corrected, performed at an outside center, and on the right with us, NaF non-corrected. So just to compare, there's no specific pathology on this slide. It's just to compare image quality and spatial resolution. So you can see that NaF does definitely offer a better resolution. Another patient, 1 week apart, MDP SPECT. This one is corrected on the top, and the NaF is non-corrected at the bottom. So even if it's non-corrected, you still gain from increased resolution. And a third example, this was MDP, but scanned on a digital CZT SPECT camera, corrected top line versus bottom line non-corrected NaF. So again, even with the digital SPECT technology, NaF still wins. So ultimately, what does this mean? Can we quantify if NaF really outperforms MDP? Well, there's a study prospective study in 2006 looking at a series of 44 patients, high-risk prostate cancer, and comparing specifically MDP SPECT versus NaF PET CT. And MDP SPECT showed a sensitivity of 92%, specificity of 82% compared to NaF PET CT, which essentially was perfect in their study. So I guess that answers the question. We'll just go for coffee, or no, let's no. So before we get ahead of ourselves, we could look at other data. 2017, another prospective study with high-risk prostate cancer. So here the numbers are more comparable between MDP SPECT and NaF PET CT. In 2019, prospective study, 81 patients looking at, again, prostate cancer, intermediate and high risk. They showed no additional benefit of doing a NaF if the bone scan is negative, so no difference in sensitivity. In 2019, another study looking at prostate cancer, this time meta-analysis, looking at 12 studies, over 500 patients. A per patient analysis showed a pooled sensitivity of bone scan, of NaF of 98% and a pooled specificity of 90%. When looking at a lesion-based analysis on nearly 2,000 lesions, similar sensitivity, but the specificity wasn't as high. Overall, though, they did show that NaF outperformed conventional bone scan and SPECT CT using area under the ROC curve. So if we compare, pros and cons, one from the next, ultimately, we're getting an increased bone to background ratio in a shorter imaging time for NaF. So this is due to minimal plasma binding, excellent first pass extraction, faster clearance from blood. And this is done, again, in a smaller amount of time. But we also have to consider other factors. So NaF is more costly, so 3 to 4 times the cost. Also, this is just the product. This doesn't factor in the camera time or other operating fees. You need a cyclotron, access to a cyclotron. F18 is made in a cyclotron. Radiation exposure to technologists. So, the lower energy of technetium versus the higher energy of F18. Camera availability. So, in Quebec, we have many PET CT cameras, but that's not necessarily the case everywhere. So the availability isn't definitely comparable to gamma cameras. And even if you have a PET camera, you have to manage the time, right? Because it competes with FDG and it competes with other tracers. So you have to fit these patients in, and they may not be worthwhile depending on what your patient population is and what your mission is. So just wanted to show everyone a few cases with NaF, just to kind of get a taste for it. Giant cell tumor. So I guess, again, something that we would expect, something similar to what we see with MDP, intense uptake, peripherally, centrally photopenic. This is another case, patient presented with a lytic lesion in the right femoral head. So on NaF, we see that there is mild uptake corresponding to this lesion, ended up being a low-grade chondrosarcoma. This is a case of metastatic rectal neuroendocrine carcinoma. So kind of what you would expect anyways with MDP. So this is where it gets a little bit interesting. People wonder, well, with NaF, am I going to detect more lesions? Am I going to see stuff that I don't see with MDP? So taking an example of metastatic RCC, overall, we see a few here, lesions here that are uptake the radio tracer. If we take a closer look, so here information from the CT, so large renal mass, and there's another metastatic mass in the left femoral or inguinal region. That's eroding the bone that we can appreciate on our images. Another case, another RCC. So here looking at the rotating MIP, we see a few lesions. So we see maybe one in the scapula, one in the rib. And looking through the rest of it, not very obvious of any other lesions that pop out. Maybe if you look close, you might see a few. So here's the rib, here's the scapula. So yeah, definitely corresponds to a lytic lesion, that's fine. This one's less obvious. So T-spine, very low grade uptake. It's there, but you gotta look at it. When you look at the CT, corresponds to a lytic lesion. However, there's a lesion in the sternum that we don't see at all here. So again, does it outperform NDP? Not in this case. A third case, metastatic RCC. So here we have the cursor on a posterior rib. So we have mild activity peripherally with central photopenia, so likely a lytic lesion. So here we have the AC, the corrected acquisition. So we see it a little better here with the benefit of correlating to CT. When we look at FDG, you can't miss that one. And there's also another lesion that we saw on FDG that's in the pelvis. So now if we go back to the NaF, not so obvious. So you're starting to see a lot of similarities here that just because you're using a PET tracer that definitely has better spatial resolution doesn't necessarily mean that you're going to be detecting more lesions, particularly in certain pathologies, such as cancers causing lytic metastases. An example of multiple myeloma. So here we do have peripheral activity to the mass. But the patient has also had previous lesions, a lot of lytic lesions distributed throughout the spine. However, these are, according to the dossier, patient with a 30-year history. So likely these are treated lesions, so wouldn't necessarily light up regardless. But the issue remains with the lytic lesions. So maybe a bonus case. I'm gonna wrap up very shortly. 25-year-old, right 11th rib lytic lesion, sent to us to evaluate. Not much activity. There's a little bit, not that much. So probably, you know, a benign lesion, either a chondroid lesion or an EG. Here, a patient, a 47-year-old woman with history of breast cancer. Essentially negative scan with exception to the left humerus with mild activity. So this on CT turned out to be most likely an enchondroma. So some take-home points comparing NaF versus MDP. So there is a slight gain in sensitivity, but really depends on the pathology because as we saw for lytic lesions, it definitely can go undetected on NaF, which is not really any different than with MDP. I think the specificity is probably similar to MDP. Better spatial resolution, there's no doubt. I mean, you know, you can kind of compare it to driving, you know, your regular car to work or buying a nice luxury car. I mean, you still get to work, but the experience is much nicer. It's not recommended, just a note, not recommended to change between, flip-flop between modalities on follow-up. So if patient starts with bone scan, switching to NaF for the next follow-up and then switching back to MDP for the third follow-up, not recommended because it's difficult to compare, you know, between modalities. You know, our opinion, I mean, I love it personally. If I could replace all my oncology bone scans with NaF, I would do it, but it's difficult to justify given the added cost and limited camera time. So I just want to say a thank you to my colleague, Dr. Eric Turcotte at Sherbrooke for gifting me a lot of these slides. Very helpful. So thank you very much.
Thank you very much, Dr. Ciarallo. Sodium fluoride PET imaging, I certainly have no experience with, so I think it's something that more of us will probably see in the future, and it's good to see some images and direction. I think Dr. Jen is also on the line, so we'll open up for questions. If anybody has any questions, feel free to come up to the mic. I'll just start with one question, Dr. Ciarallo. What about, do you notice any differences between PSMA imaging and sodium fluoride imaging for prostate cancer metastases? Are they typically pretty congruent for bone lesions, or what have you noticed there?
Yeah, we've had a couple patients where we saw osseous lesions. One patient in particular, I had this rib lesion. They were, rising PSA. They didn't really know, so they started with a bone scan, and there was a lesion in the rib, but nothing else. And CT, soft tissues were negative. So like all the conventional workup was negative, and the bone scan just showed this one rib lesion. And so I reported. I mean, I think, well, in the context of rising PSA, I think this looks like metastasis. So obviously, they didn't believe me, and they ordered PSMA PET. So on the PSMA PET, it confirmed that this was the lesion. I don't remember if there were other little nodes, to be honest, on the PSMA PET. But yeah, in our experience, the findings seem to be congruent. Obviously, we have to interpret it with CT. The specificity isn't 100% for NaF, but I think in general, there's no real major surprises, especially for prostate cancer.
Okay, Dr. Lamoureux.
Oui, François Lamoureux. Thank you so much, Anthony and Dr. Yin, for your nice presentation. I have a question for Professor Jean. Do you recommend now that state of the art, we have the obligation as nuclear medicine physician to do investigation of stress fracture, to do a SPECT CT on all patients?
Thanks for that question. Can you hear me? Is my
Yeah.
work? Okay. No, I don't recommend. So I just want to make sure the audience is not getting the wrong impression. To put things in perspective, we have a very busy practice. A lot of those cases that you see me present come from a rotation where we are monitoring 6 clinics concurrently in live in real time. They all have to be checked and they all have to be reported. So I'm not one for full investigations on everything. So I guess short answer to your question, it depends on the case. If it's a clear-cut clinical history and it's an obvious stress fracture, I don't think you need to SPECT CT that if the planar images are suggestive. Now, if there's an extenuating circumstance, if there's anything unusual about that, for example, that foot I showed you, right? I don't remember the circumstance. There was some reason why I opted to SPECT CT that. So my short answer is no. If you are pretty sure it's a very classic appearance, the history is appropriate, and it goes with the clinical findings, and it goes with everything presented to you on paper, I don't think so. If there's anything unusual, then yes. Knowing that as soon as you turn on that SPECT CT, you are going to get lots more information that you'll have to deal with. So no, I don't think it's necessary. It depends on the clinical case.
Okay, so you will recommend that we revise all the information of the patient, of the chart of the patient before doing the test. So it will change a little bit our practice, because at least in my department, when we do a bone scan, most of the time, I don't revise the clinical information before the test is done.
Yes,
So
and I'm with you there. I fully sympathize with you. And I have to say, those pain diagrams I showed, they're an absolute luxury. Like, I can't tell you how much that is worth money. And yeah. At first, when I introduced the request, my technicians were completely annoyed with me. But I think over the years, they've accepted how powerful it is for me to see, because I can't be there to examine the patient myself. I don't have an answer for you. I mean, as much information as you can get clinically, the history, as you can see, it all matters. It all will determine whether or not you get the right answer. Right?
Well, when we do PET study, we revise all the requisition before doing the test. But
Yes.
would you suggest that we'll do the same thing for the planner with PET study?
I within limits, within what's practical. I mean, you can only answer that for your department, right? I don't insist, but I can tell you though, and hopefully my presentation has trying to demonstrate the more information you get, the more likely you are to arrive at the correct answer, right? Unfortunately, that's just the nature.
It was a magnificent presentation. And
Thank you. Thank you.
Thank you so much, Dr. G.
You're welcome.
Okay, we have another question on the left here.
Yeah, good morning. This is a question for Dr. Jen. I'm Yin Wee Xiao. I'm a nuclear medicine and radiology from Southlake in Newmarket, Ontario.
Welcome.
Thank you. I really like your thinking regarding SPECT-CT, and I'm also a big fan of it. Especially the co-registration between functional and anatomic imaging. My question to you is, do you do SPECT-CT on everybody? Or is it on a, because you mentioned that you were in a very busy practice. So is it sort of, so do you apply the same protocol to everybody, or is it on a piecemeal basis? And part two is, if you do apply SPECT-CT to everybody, have you encountered the issue of sort of resistance, I'll say resistance from the technologists regarding the amount of added radiation, because I seem to be swimming upstream with respect to that. Okay,
thanks for the question. I think a lot of people would probably be thinking the same. No, I don't. You know, my colleagues in the past have presented, why don't we just routinely SPECT-CT everybody head to toe? I'm totally against that. I don't think that's the right thing to do. It's not of any benefit to all patients. So the short answer to your question, no, it is your call. So as I pointed out, both in our in-hospital departments and in our very busy outpatient, the cases are checked in real time. You decide whether or not you're going to SPECT-CT. Now, there are some set clinical problems. You can imagine what they are, right? Where it's virtually 100% guarantee you are going to SPECT-CT. There's no ands, ifs, or buts. But most of the time, it's your call. You have to justify doing the SPECT-CT. There has to be a reason. Because simply put, we can't afford to be SPECT-CTing everybody routinely. That's just not going to happen. I mean, that's not practical. That's not realistic, and I'm not promoting that for a second. Resistance from the technical staff. They've kind of accepted the fact that we're all SPECT-CT happy, and you know, I would say though, they've become very proficient at it. Technically, you know, they are just superb at doing the most difficult, unimaginable patients, thanks to our demands. But I think over the years I've convinced. I give some talks to my technical staff themselves. They see the benefit. They absolutely know the benefit. And I can assure you, they will actually go out of their way to try and convince some patients who they think really need the SPECT-CT. You know, there are patients who decline, right, because of radiation concerns, etc. They will even go out of their way to try and convince the patients on my behalf. So no, that's not a problem, not in our department.
Okay, thank you.
I'll add to Dr. Jen's comments. The technologists are more concerned about time than radiation, I think. They don't want to be there until 9 o'clock at night. And what our techs I've noticed do is they start the SPECT of where they think we'll want it while they wait for us to check the case. So, you know, the SPECT will already be half done. They haven't done the CT component yet. And then we get back to them and we say, please do SPECT-CT. And at that point, it only takes them an extra 5 or 10 minutes. Or if we say we don't want it, then they just tell the patient to leave and just cancel the SPECT. So they're time saving that way and makes them more amenable to doing it. We have another question on the right here.
Reza Berenji, I'm from Los Angeles, long way from home, but we do exclusively sodium fluoride for many years. And I second that the technologists always question, do you need a SPECT or not? So I think that sodium fluoride resolved that issue. So we get the scans done and we review it. I have just a few comments about the sodium fluoride. What we do whole body, and what we try to get the legs on a faster scan, because usually there's not much pathology there, but we get a full scan done. And then the question about PSMA versus bone scan, and what we realized since 2018 that we started PSMA, numbers on bone scan and sodium fluoride drop substantially. So if you haven't started sodium fluoride and you're going to move to PSMA, that's probably you're not missing much on the oncology part, at least. Other comment that is probably future of sodium fluoride is the cardiac application of sodium fluoride, and there has been a lot of work done, mostly Cedars-Sinai, our group, and in Scotland on coronary artery disease and application of sodium fluoride in that, and also in peripheral arteries. And I think comparison of sodium fluoride versus MTP, and I think the cost, of course, is important, but the time patient spend in your department, especially during the pandemic, keeping a patient for 4 hours in your department versus getting them done quickly and send them out of department, that was a big advantage of doing PET in our center. So, but excellent talks. I really enjoyed the SPECT-CT images. Those are excellent. That applies to our SPECT-CT. We have, I think the CT that comes with the SPECT machines are pretty little bit lower quality, and the metal artifact reduction is very important. We continue doing 3-phase bone scans, but sometimes I have to move the patient from our SPECT-CT scanner to the PET-CT and get another CT with metal artifact removal to just get a better view of it. So that's important to keep. If you're getting new scanners, make sure that metal artifact reduction is included. It's very important in application in evaluation with prostheses and things like that. Thank you.
Thank you. If there are no further questions, it's 9:45, so I think we are scheduled for a break. I think it's 15 minutes. Thank you.
Thank you.